Welcome to our session, How to Make Your Global Health Program More Interprofessional, a Blueprint. This session is jointly sponsored by the University of Kentucky Office of Global Health Initiative, the Center for Interprofessional and Community Health Education, and the Umbro Foundation. We're so glad that you've chosen to spend your time with us today. I'm going to ask our room moderator, Kev, to keep an eye on anyone who might be in the waiting room. And if you do have any technical problems throughout, he's there to assist. The first and probably most important thing I'll tell you is there's a button that looks like a globe at the bottom of the screen. Because we have simultaneous interpretation, English, Spanish, Spanish, English, go ahead and click on that globe button and you should be able to change to the language you wish to hear. Just choose that language. So I'm Melody Ryan. I'm a professor of pharmacy and the assistant provost for Global Health Initiatives at the University of Kentucky. And I will be your moderator for this session. So we'll begin with some introductions. I won't spend time reading everyone's biography right now because I'll do that as I introduce folks, but you'll be hearing from each of these people as we go throughout the day. And I'd like you to appreciate that we do have a very broad interprofessional perspective at this point. So I'd like to just acknowledge all these people will be speaking, and we're thrilled to have such a big group. Going on to the objectives, here's what we hope you'll get out of the day. An appreciation for the benefits of interprofessional education and care, and to see how it might affect your global health program. We also hope to give you the tools to begin to think about how you can identify which other health professions with whom you would like to work, and you can leave here with a plan for developing your team. So that you can develop that plan, we have put together a worksheet in Google Docs that you can use to keep notes if you like. I'll drop that in the chat here. If you click on that, click on File, Download, and make a copy, and then you can have your own copy for that. And otherwise, you'll be putting that in the same file as everyone else. So that's probably a good idea to make sure you're managing that. So here's our agenda for today. We will alternate between some brief presentations and some brainstorming time where we'd like to hear from you and the things that you're thinking about doing with your interprofessional team. And we're going to give you a number of examples from short-term experiences to clinics, and we'll have a nice salsa dancing break. So we tried to build in some stretch and movement breaks for you. Also a rural team in a middle-income country, a virtual model, and we'll wrap up with some questions. Now, we do have that time for questions and answers at the end. But if you are thinking of questions, feel free to drop them in the chat and we'll be monitoring that throughout. Or we'll have times to unmute and discuss it as well. So please take advantage of the expertise that we have in the room and the ability to use that. So with no further ado, we will go ahead and talk about some polling questions first. So the first one, we'd like to get an idea of who's in the room. And Kev, can you deploy that first one? Or is that me? That's me. Okay. All right. So let us know what profession you're with. Now, I will tell you that Zoom only allows 10 choices. So I had a lot more professions I would have liked to list. But for some of you, you're going to have to probably pick something else. The second question is finding out how much experience you have working with other professions. So none, working with one other, two other, or three or more. What type of country you're from, high income, middle income, or low income. And if you need simultaneous interpretation into Spanish, please let us know. And we'll be able to provide that throughout. Again, to get that, you click on the globe at the bottom and choose either English or Spanish, and you'll be able to hear in that language. All right, probably everyone's had time to put in their answers, so let's look and see what we have. Looks like we have physicians, nurses, pharmacists, public health professional, students, something else. We have experience with interprofessional care, everything from 3+ to none. We have a good representation of different countries. And we do have some interest in Spanish interpretation, so we'll keep doing that. All right. And I just realized you all couldn't see that, so I am sharing that now. I'll just scroll through. Okay, with no further ado, then now we'll go with our first presentation. Dr. Ballard will talk about the impact of interprofessional care. James Ballard is a director of the University of Kentucky Center for Interprofessional Health Education and is the associate professor in the Department of Family and Community Medicine. He is chair of the American Interprofessional Health Collaboration and a member of the Interprofessional Education Collaborative Expert Panel entitled Leveraging the IPAC Competency Framework to Transform Health Professions Education. Dr. Ballard is a graduate in psychology from the University of Notre Dame and received a master's of educational psychology from the University of Kentucky and a doctorate in education at Northern Kentucky University with an emphasis on interprofessional education. Take it away, Jim.
Okay, thank you very much. It's a pleasure being here. How do I advance the slide or do you?
I will.
Okay. I think it's important to start. First of all, apologies for the people that this may be a review for some folks and it may be new for others, but I think it's always a good idea to really understand exactly what we're talking about, because there are some misperceptions about what is interprofessional collaboration and what is not, as well as what is interprofessional education. So it's always good to start with some definitions. So interprofessional collaborative practice has been defined by Freeth as two or more professional disciplines working together as a team with a common purpose, commitment, and mutual respect. It's also been described by others as it draws together a variety of professionals with a common vision, having the potential to explore solutions from different perspectives and supply resources. I think the basic underlying premise of both of these is that there is an interdependence and a cooperation among members. Just throwing people in the same room together does not make it interprofessional, nor is it the same as interdisciplinary. Sometimes, you get hung up in the language. We'll try not to do that, but we just wanted to make, what we're talking about here is interprofessional, for example, a physician, a nurse, and a pharmacist working together. They're working together cooperatively. They're using problem-solving strategies that are dependent on the background of both of them. A lot of this has been unfolding over the past few years, but a lot of this was informed initially in health professions by crew resource management, which was part of the airline safety focus. It used to be that if, and I'm overstating this, making it too simple, if a flight attendant saw that the wing was on fire, they were not supposed to talk to the pilot and tell them that. Not really a good way to improve ensure safety. But so there is a focus on communication, understanding what the situation is going on at all time, problem solving, and make that mutual problem solving and mutual decision making, and of course, teamwork. Next slide. So what's the point of it in healthcare? The bottom line here, it improves patient outcomes. There's a lot of evidence that has emerged since the early 2000s, actually, that has indicated that it was. Before that, it was kind of it was described as a truism that begs for evidence. But really, there is some emerging evidence that is really, really good. These, I've selected the next few. You can go ahead and change it, Dr. Ryan. These were seminal studies, if you will, that were done early on, and they used random controlled methods as opposed to other methods. So there's some the rigor of them is helpful. We can see that there have been some instances where it's improved patient satisfaction and quality indicators. In the area of diabetes, quality improvement goals were achieved using an interprofessional team. This one, if you get a chance to read this one, it's fairly old now, 2002, but there were some significant declines in error rates in an emergency department before and after, or not before and after, but between the control group and the collaborative group, dropped the error rate from around 30% to around 5%. Having a pharmacist involved was led to a simplified medication regime for complex patients, and it has improved care for folks with diabetes. It's improved safety in the operating room, and it reduced sentinel event alerts of infant mortality, morbidity in delivery. Next slide, please. So the emergence of interprofessional collaborative practice. This is not new. We sometimes think it's new, but it's not. It's really been going on for a long time. Back in the 70s and 80s, there was an annual interdisciplinary healthcare team conference that was really undertaken by a pioneer in interprofessional education, and that was Bud Baldwin. He's got an incredible number of papers that he's written over the past few decades on this. They're being compiled right now by the National Center for Interprofessional Practice and Education, and they'll be available for everybody here pretty soon. One of the things that's been called health professions transformation or health systems transformation has been happening for a number of years. And Frank and some other folks have talked to this about. This is one of the most important emerging transformation strategies in healthcare, is the idea of working together in collaborative teams. And of course, it's been supported by other platforms too, beginning with the Pew Health Proficiency Commission. Importantly, there was 3 primary publications. First of all, being To Err is Human, that came out in the late 90s and talked about the overwhelming, frankly, error rates that are occurring in hospital settings and some things that could be done with it. This was followed up by Crossing the Quality Chasm, where they talked about how can we not only impact those errors, reduce them, but also lead to quality improvement in healthcare in general. And of course, if you're going to be doing all of this and affecting the healthcare system, it's helpful to look upstream, if you will, to look at health professions education. That's what happened in 2003 with the Bridge to Quality. Among other things, they suggested that students, rather than being trained in silos as they had been and still are to a large extent, that they at least have some experience working in teams so that they're ready to function as a team when they graduate or finish their training. Next slide. Recently, well, one of the areas of transformation that we're talking about here, the Institute for Healthcare Improvement, talks about the triple aim, which is to have improved patient outcomes, obviously, improved patient satisfaction, and improved per capita cost. This was spurred on by the ACA, and this is probably one of the reasons I would say that interprofessional education has really been spurred on in the past few years, because it's based on payment methods. As opposed to fee for service, the Affordable Care Act called for new payment models, which would, for example, value-based payment, where it's contingent on the quality of the care. And if your payment is contingent on the quality of the care, as opposed to simply the procedures that you do, it really behooves you to use a team, because folks, most of our patients, especially our chronic ones, are too ill to be entirely affected by one health professional. Next slide, please. This has been followed more recently in later years by the quadruple aim. We recognize that there's a need to make sure that our health workforce is healthy, especially when it comes to things like emotional exhaustion. And there's some evidence that's coming out that indicates that effective teams actually seem to have a higher perceived locus of control over their own life. And this can lead to reducing or mitigating some of the stressors in life, or stressors in practice. More evidence indicates that it's related to engagement as well. having a team. So the greater engagement you have is related to higher levels of teamwork, which is related to higher levels of job satisfaction. So what we see here is that there is an improvement through interprofessional collaboration for the patient, but also for the health team that's treating the patient. And this is, of course, positive. Next slide, please. So if we're going to have interprofessional collaboration, like we've talked about already, you need to have interprofessional education. We need to train people. It's not likely that they're going to be trained in a silo in their health professions programs that spontaneously combust into team players when they get out into the real world. This has been called for beginning in the early 2000s. Barr was one of the leaders in this. He said that interprofessional education leads to improved communication, appropriate division of labor, recognition of diverse expertise, all of these things here that are listed. And of course, that leads to better patient outcomes. Next slide, please. So once more, with definitions, if you work at a university, you have to define things. It's in the rule book. Interprofessional education has been defined as when two or more professions learn with, from, and about each other to improve collaboration and the quality of care. Some of the components of this is we're looking at a systems-based, holistic decision-making process. That's what we're trying to instill in our students. We want to empower them to work together to solve complex problems. There are probably no more complex problems than human beings who are ill or trying to keep human beings healthy. And this, as I said before, surpasses the scope of any one profession. Anyone that's in health professional education knows that the curricula grows and grows and grows. We never throw anything out of it, trying to prepare them the best we can. But there are, for example, in medical school, some medical schools offer a block of pharmacology. We have pharmacists, for example, that have a 4-year block of pharmacology. So it really is helpful to bring them into the fold and making decisions about medication and other things. Next slide, please. Okay, about 2011, we said, okay, we're supposed to be teaching interprofessional collaborative students to become able to be interprofessional collaborative practitioners. So what does that mean? What are we going to teach students? We need to really kind of systematize this. And this IPAC, the Interprofessional Education Collaborative, came together with all the accrediting agents for the various health education programs that you can see listed there. And they came up with 4 domains. The first one is values and ethics of interprofessional practice. That's just understanding and respecting others, is how you boil that down. Roles and responsibilities. If you're going to respect others and, as we say, try to make sure that your teammates practice at the top of their license, how can you do that if you don't know what the top of their license is? So understanding their roles and responsibilities is very important. Also, interprofessional communication. This is a different one. This is typically where we start with students, and they always balk a little bit because they say, I've been talking all my life. Of course I can communicate, but really it's a special kind of communication that they really need to work on. And then, of course, understanding teams and teamwork is important as well. Next slide, please. This was followed up more recently in 2016 by an update. Basically, the competencies are the same. You see the first one, which is values and ethics, followed by roles and responsibilities, communication, and teams and teamwork. But it was done to really make it more inclusive of not just the health professionals that they typically deal with illness and wellness. Is to include populations, making sure that we keep the population right. This would include social determinants of health. We would talk about prevention and promotion of health, and also policy. We want to make sure that policies are involved in this as we transform the health system and by proxy the education system. Next slide, please. Recent milestones in the United States, at least, the accreditors have gotten together and said, okay, and this includes for medicine, the LCME, and 24 other accrediting folks. And they recognize that accreditation is a big driver in what is taught in interprofessional education. And they came together to make some decisions about what they think is the best case scenario or for interprofessional education. They produced this guidance. Now, this is a guidance, it's not a mandate. it was consensus that they came up with, that that they are suggesting folks as they begin the process of developing, implementing, and evaluating interprofessional education strategies. Next slide. Basic recommendations are that interprofessional plans should include a clear rationale that articulates a vision, framework, justification. What they're saying here in part is that it should be theory informed. And there are some emerging theories and some theories that have been around for a long time that really can help guide us here. It should be based on outcomes, what we want the students to achieve. It should be deliberate and sequenced across modalities. When I say that, I mean, classrooms, extracurricular, clinical, and it should be integrated into existing curriculum and longitudinal. So again, it's not an inoculation that we can give them one time and they're going to be healed, as it were. It's something that occurs over the course of their education. Finally, there should be assessment and evaluation. This is true of any educational endeavor. If you're not evaluating and assessing it, you shouldn't be doing it. Or if you are doing it, it should be evaluated and assessed. It's probably a better way of putting that. Next slide, please. It also talked about multiple levels of leadership, because what you're doing is you're changing a culture. When you're changing health professions education in any way, you're also changing the culture. And this is a pretty significant change. And there should be, this document suggested that there should be institutionalized support at the provost level, the president's level. For example, my center will be reporting directly to the provost here in the next couple of months. It's a mixture right now. Program leaders, things like deans and departmental leads, should be involved in it. It should be deliberate design. There should include both in-person learning, which can be synchronous, like case discussion, service learning, observations, rotations, things like that, and collaborative online learning. So there are different modalities that can be used, but again, it needs to be deliberate, longitudinal, and evidence-based. Next slide, please. Here's a visual representation of what they have. And again, the theory that this is based on is interprofessional identity theory, which is, and this is translated into the interprofessional socialization model. And I just realized you can't see this very well. So if you look on the right side, the green boxes, as opposed to the left side, the purple boxes, what we're talking about there, that's professional identity development. We socialize students into our professions as we train them. That's part of what it is, whether it's intentional or not, it is happening. And we think that that's good. I mean, you can't do without that. If you want people to be socialized into the profession they're going to be, because every profession has its own language, its own cultures, et cetera. It's like little countries, quite frankly. That's why I think global health really keys into this very effectively. But at the same time, we want a dual development, have what we're calling a dual identity development. That's that first orange circle at the bottom there, where they recognize they have an identity as a health professional, but they also have a dual identity as a health professional within a collaborative team. And ultimately, this is the purpose of this, is to improve the quality of healthcare delivery and patient safety. Next slide, please. Okay, here's an early demonstration of, I will tell you, when I caught the bug for why I think the global health is such an important area for interprofessional education, and why interprofessional education really needs to involve global health. We started with the team, many of them are on this Zoom today, and we did an analysis of a course that we had that developed the students to go to the shoulder-to-shoulder brigade in Ecuador. We did a qualitative analysis. Actually, it was a mixed method, but the qualitative was the most important part in my mind. And what I saw from this was that there was a decentering. When I say decentering, I mean from a Piagetian point of view, becoming less, focused on your own profession, on your own culture. So the result was a movement from what my profession can do for the patient to what the team can do with the patient rather. And I saw this at both a cultural level and a professional level. Next slide, please. At the cultural level, I saw that the students were talking about a deeper respect and value for other cultures that they hadn't thought about before. They were also reflecting on their own biases that they have as a member of one culture. From the professional point of view. There was, again, the respect and value for other professions. See why the connection between professional and culture here. There was an understanding of the roles and scope of practice. Well, that was intentional. We wanted that to happen. An acknowledgement that collaboration and interprofessional communication was important. And they were able to take, importantly, they were able to take the perspective of others and recognize biases. To see the similarities between culture and profession are profound here. Ultimately, what this is going to do, both of them together, is help them understand the complexity of care, how culture impacts it, how professions impact it, and help them understand the importance of team and the need for holistic care. Next slide, please. So in summary, interprofessional collaboration has been demonstrated to improve the quality of care for patients and populations. I don't think there's a doubt about that at this point. Interprofessional education, relatedly, that is intentional and is intentional and required by most accrediting bodies is necessary to develop professionals who are capable of collaboratively practicing. And global health initiatives are an important context for IPE, and both are impacted positively when you combine them together. I will pass this back to Dr. Ryan. You're muted, Melanie.
Thank you, Dr. Ballard. Now that we have a basis for understanding the impact of interprofessional collaborative practice, let's think about the communities in which you work and what those other professions might be able to contribute to your community. So feel free to unmute and share, and I will stop sharing the screen so that we can see each other. And remember, if you would like to develop your own blueprint and have a place to take notes, I will drop that Google document link in the chat again. So feel free also to ask any questions that you might have of Dr. Ballard. So who would like to volunteer to tell us something about the community where you work and where you see gaps maybe in interprofessional care? So I'll start, and then maybe it will bring some thoughts forward. When I began working in the neurology clinic before, they had never had a pharmacist in the clinic, and they didn't quite know what to do with me. So I began by doing medication histories on all of the patients, and naturally I found many things that they either were not telling their physician or weren't obvious to the physician. One of the first ones I found was a patient who was coming in for tremors, a small child. And when I looked, he was taking albuterol orally instead of inhaled, where the physician thought it was always inhaled. Well, he was coming in to see us for tremor, which was definitely caused by the albuterol. So just having someone look at the medication list and think of it as a pharmacist would was a real gap in care at that point. Can you all think of other similar things, or tell us a little bit about the patients with whom you work?
I think Pablo has his hand up.
Oh, go ahead, Pablo.
Hi, Well, my name is Larry from Nigeria. I work for an organization called Arise. It's supposed to be an interdisciplinary research on sickle cell, newborn screening to be precise, in Africa. And I'm working on the implementation science bit of it, and then communication and dissemination. And I know sometimes different professionals like to work in their silos, like just in their groups. And we used to have issues actually relating across all the work packages. So we've decided to do a communication plan where each of these groups will feed back to a main system. So everybody knows what everybody is doing and everybody knows everybody's role in the research. And that way it doesn't get too ambiguous for every other person. And then sometimes I'm not a health professional, and sometimes you can get writing protocols and all that can be a bit tasking. But well, they've simplified it now on how we can just understand each other so that the research will be a success eventually. I think that's all I have to say about it.
Oh, I think that's a really great example of an area where you need multiple health professions. You know, sickle cell is a complex disease. Not only do you need people in the healthcare professions, but you also need people in social services and ways to connect patients to care. Do you agree, Laura?
Yes, I agree. I agree. And sometimes actually making the community informed on it, because now you're telling them that you need to get blood spots from their newborns, and it's strange. So now community sensitization, and then feeding back to parents, you know, giving parents feedback on all that can be a bit tasking. Yeah, and most of the health professionals get overwhelmed. You know, going to the communities and asking them to be part of this research can be a bit tasking. So you need social scientists, community actors to be part of it also.
I think those are really excellent points. So definitely involving the patient in the patient's care, which sometimes we forget about. The patient needs to be involved in his or her own care. There's a comment in the chat about all of the United States needing chronic disease prevention experts paid full-time. Do you want to elaborate on that a little bit? It's MS. Perhaps can't talk right now, so that's fine too.
Hello.
Oh, there you are. Yes, please go ahead.
Yes, what I meant is that at least 2/3 of the top 3 killers in this country and pretty much in the world, heart disease, cancer, and it used to be diabetes, but now it's COVID third. Anyways, they are preventable, and we knew that for a long time. And a joint American Cancer Society, American Heart Association, and American Cancer, right, did I say that? And diabetes. A joint statement was printed some 20 years ago, how physical activity, nutrition, and stress reduction and other lifestyle intervention could prevent 2/3 of these. And here we are at pretty much the same or worse, and now a pandemic at top of everything. And these diseases and comorbidities happen to be top risks for COVID morbidity and mortality. And COVID is now a vascular disease known, so it's just skyrocketing and snowballing. And how much of the medical care is spent in this country? Pretty much like in most developed countries, around 2%, at 2%. So now that says it all, you know. Whoever said the definition of insanity is doing the same thing and expecting different outcomes, they were right. It doesn't matter who said it, but we can see what's going on.
You know, you make a really, really good point here. And I think this also speaks to the need for collaboration. I think there's more of an emphasis now when we talk about collaboration, we're not simply talking about collaboration amongst the typically thought of health professionals. We're talking about social workers. We're talking about institutional collaborators. And things that we can do, you know, collaborating with folks in the community, paraprofessionals in the community, community health workers. These are some collaborations that we need to be working on to impact some of these prevention needs that you're talking about. And I think COVID really brought this. We knew about this beforehand, but COVID was an interesting situation where no one was an expert on COVID, and we had to collaborate. And by collaborating, and I'm talking about governmental collaboration, I'm talking about universities, I'm talking about world collaborations. This whole collaboration was the part that helped us come together and impact it positively, the outcome. I won't say cure it because I have nothing of wood to knock on here, but you know, it's really, it was instrumental. So thank you for that. That was a very good point.
Thank you. Here, we hope that we're going to come up with something to spur action.
Right.
Absolutely. All right, great. So let's give you all just a few minutes to kind of stretch and grab maybe another cup of coffee or whatever you like at this point in your day. And we'll be back in 2 minutes. So, okay, 2 minutes goes really, really quickly, doesn't it? So welcome back. Our next speaker will be Dr. Tom Young. He's the Jim and Suzanne Elliott Family Professor of Pediatrics at the University of Kentucky Department of Pediatrics. He's a graduate of the University of Louisville College of Medicine. Dr. Young completed his pediatric residency at Riley Children's Hospital and a community pediatric fellowship at Pittsburgh Children's Hospital. He serves as chair of University of Kentucky Shoulder to Shoulder Global and director of the University of Kentucky Pediatrics Global Health Track. Dr. Young will illustrate an interprofessional care and education model in his example of a short-term experience in global health. Tom?
Good afternoon, or good morning, good afternoon, good evening, depending on where you're at currently. It's exciting to be able to present an example of interprofessional care in the short-term brigades. And if you can get the next slide, Melody. What I thought would be useful first is give you a little bit of background of how we got started and how we evolved in the process of performing interprofessional care. And I have to admit, our initial process was solo focused on medicine, but it's rapidly evolved over the years to interprofessional care and how we prepare our students for that experience. Our initial interest in this evolved around involving the Partners of the Americas. And for those who don't know, Partners of the Americas was started over 50 years ago during the Kennedy administration, around the same time that the Peace Corps was started. And what Partners of the Americas does, it matches states in the United States with countries in Central and South America. So Kentucky was matched with Ecuador. And our universities had a 50-year history of a collaboration with that organization. So when we did our very first initial trip, it was involved only with myself and pediatric residents, and that was in 2002. We coordinated this with Partners of the America chapters in Ecuador, and our initial trips included visits to the Andes communities in Quito, in the Amazon area, and in Santo Domingo. So there was actually a chapter in Santo Domingo that we began initial exploration of potential of a longer term project, because it became clear that just taking a short-term trip for a week and coming back home was not the ethical way to do global health. So we did some initial service and focus groups to see what the need was in the community and see what the community would like us to do. So next slide, please. So our initial planning, see the slide on the bottom left was actually at the current site of our health center. And this was a focus group that we did with the community to discuss what their needs are, what their interests are, and ways in which we could partner with them to provide some healthcare in the community. The picture on the right was actually involved with business and community leaders of Santo Domingo. Again, discussing the same things. How do we partner with the community? What are their interests? And how do we proceed to make a difference in health in the community? Next slide. So we were fortunate to finally able to open up the Central Salud Hombro, which is in Santo Domingo, Ecuador in 2007. This was initially done in partnership with a Catholic social service agency called FOSCA. And now this has evolved over to our own nonprofit called Hombro. So we actually started the initial clinic on the bottom right. You can see the clinic building before it was renovated. It had actually been an abandoned clinic building in the community. But they said, if you can figure out a way to staff this program, you can use this facility. So the bottom left picture shows actually what we call a minga. A minga is when the community comes together to do a community project. And these are community members who actually came in to clean, paint, and to fix up the clinic before we opened. And in the center, you can see our original staff. And happy to say that Dr. Carrion, who was our initial hire 15 years ago, is still active with us and a great physician leader of our project. So at that point, we formed at University of Kentucky a shoulder-to-shoulder global leadership group, which included community members as well as UK faculty from different colleges of medicine. Next slide. So just to give you a picture of where we're at, this is the clinic building, and our site is in the center of this photo and shows the surrounding type of community that is present. Next slide. So again, there's a 20-year history of Brigades. Our evolution started with the opening of the clinic in 2007. Initially, we just had one brigade per year. Then we gradually expanded to 2 per year, to 3 per year. And now we have 4 brigades per year that go to Santo Domingo and work in partnership with the clinic. We continue to add health profession, faculty, and students. And over the past probably 7 or 8 years, we made this shift to interprofessional teams in education. Next slide, please. So just to show how this has evolved over time, in 2002, it was medicine only. And 2005, we added a nursing team. 2006, we added dental teams to the project that currently are intermittent as far as involvement. 2006, public health and pharmacy came on board as part of our short-term brigades. 2008, physical therapy. And just an interesting story about physical therapy. When we first went with physical therapy, we weren't quite sure how that would work and what they would do. And it turns out that's the most popular, probably most impressive impact that we have is with our physical therapy teams that go now. 2013, we started sending physical physician assistant students and faculty. 2007, got involved in mental health and psychology, and now frequently we have psychology teams with us, which allows us to provide mental health services. We did a pilot with gastronomy with one of the Ecuadorian universities called UDLA. And in 2019, we also initiated some legal advocacy as part of the teamwork from another Ecuadorian university called UIC. And so as you can see, over time, we've added these additional teams. And I would say our core teams are medicine, pharmacy, physical therapy, nursing, and public health. The other ones are frequently with us, but not all the time. So one of our early adventures in interprofessional care is an example of this photo here. This photo has a pharmacy student, a nursing student, a physician, a physical therapist, an interpreter, and the patient. So this is kind of a team assessment that we tried. This was challenging initially to pull this together in the busy brigade, because our brigades may have as many as 50 to 70 participants, and we may see up to 1,000 patients in the week that we're there. But this was our initial pilot. And in a few minutes, we'll go over how we've expanded this model, and actually just got back from a brigade that did a comprehensive interprofessional team concept that we'll talk about. Next slide. So again, the other ways we do interprofessional care during the brigades is part of home visits. The bottom left picture shows a picture of a home of a young man with some physical disabilities. So we frequently do home visits with interprofessional teams. The picture on the right is a young boy with in an indigenous community called the Satchula that we visit frequently now with physical therapy, medicine, and nursing teams who provide home care in an interprofessional type of environment. Next slide. So some of the strategies that we have used to do interprofessional care is that all the professions during our brigade work at the same site, and it's really encouraged to have direct interactions. For example, if we have a patient that we're seeing that needs physical therapy, we're able to go over and directly talk with the physical therapist. We're able to actually talk directly to the pharmacist on site to do problem solving as a group. The students who are involved with this, who are from all different professions and interests and even undergraduates, they're all rotate through each of their professional sites while they're on the brigade. So they can have that exposure to experiences. And it's been interesting to see how many undergraduate students have actually changed their career choices or chosen new careers as a result of these experiences of rotating through these different types of professions. There are informal interprofessional interactions at our lodging site. Where we stay is very interactive, and so they get a lot of chance to interact with different professions and students in different professions. We also have interprofessional reflection groups at the end of clinic each day that talks about challenges in interprofessional care and allows us to interact with different professions after the brigade's over. Again, I mentioned we do interprofessional home visits. They were somewhat limited during the COVID times, but these hopefully will be restarted once the COVID challenges are over. We also do arena-like professional team assessments where students rotate through, and we'll have more information on that in just a few minutes. But these are patients with complex health issues that are pre-screened and have consented. And some of the photos that we show, the families have consented to share their pictures and videos. Next slide, please. So again, here's a couple of just pictures of some of the interprofessional kind of teams. But I think we go to the next slide. We actually have a video that we can just show you, capture some of the moments of the interprofessional team in action. These teams all have physical therapy involved, nursing, medicine, or clinic staff, patient, interpreters, pharmacy are all involved in these team type of problem solving for patients with complex problems. And it's important to know that the clinic team is also present during these, so they know how to follow up for these complex kinds of issues. So with this, I'm gonna turn it back over to Dr. Ballard, since he kind of led our initiative for these interprofessional mini teams. But I think, Jim, we did maybe 6 or 7 teams during this time, but I'm gonna let you go to the next few slides.
We did 8. So yeah, this is the intervention. It was, of course, again, theory-based. It was guided by a cognitive apprenticeship theory, which is simply a fancy way of saying making your thoughts visible. We used teams that had licensed health professionals and their students with them. They conducted a history, limited physical development of a problem list, and a comprehensive integrated treatment plan. These were not short term. I mean, these took about an hour and a half or 2 hours for these patients. They were identified by Dr. Christian and Mercedes, and they gave us a really good group of patients that were very helpful to work with. The professionals, getting back to cognitive apprenticeship, the professionals were asked to utilize a think aloud protocol. That is, as they worked through the diagnostic reasoning process, we asked them to think about, explain, or talk about what they were thinking and why they were doing what they were doing. This is difficult for an experienced expert clinician because oftentimes they don't They don't go through a Bayesian type thought process. It's more of a pattern recognition, but they can do it. It just involves backing up. But it helped the learners to understand the similarities, dissimilarities of the diagnostic approach utilized by multiple professions. And they could see that some of the things they were doing were similar to the way they did it, but they were thinking about different things as opposed to what the other person that they were listening to was thinking about. We did a debriefing afterwards. This was followed by, asking what was done well and what they thought that they could do better. And then we also provided feedback. I was in there as an observer, and I provided feedback to the group based on the Interprofessional Education core competencies that we talked about earlier. Again, values and ethics, roles, responsibilities, interprofessional communication, and interprofessional teamwork. Next slide, please. The evaluation we did, it was a mixed methodology. On the quantitative side, we used the Interprofessional Collaborative Competency Attainment Scale, the ICAS. This is a validated instrument. It's pretty short. It has 20 items, and it assesses changes in interprofessional collaborative competencies in healthcare students and practicing clinicians in a pre-post environment. It has 6 domains, including communication, collaboration, roles, responsibility, collaborative, patient-centered approach, conflict management, and resolution and team function. It has a 7-point Likert scale. It's a single explanatory factor. So rather than presenting data on all 20 of the items, it rolls into one factor. And we assess that pre and post. You can see here that the results of the post score, which was the mean of 6.4, as it compared to the pre 5.4 about, were statistically significant pre and post. Next slide, please. The qualitative was probably more interesting to me. We asked 2 questions. One, what was the most impactful takeaway from your experience working with a collaborative team? How, if at all, will this impact your future work as a professional? And 2, what, if anything, would have made the experience in the collaborative team better? We wanted to know both good and bad, if you will. Overall, the comments revealed that the students felt that this helped them to understand patient-centered care, helped them to understand interprofessional communication better because they actually got to participate in it. They understood the roles and responsibilities of their own profession and others' professions better, as well as the scopes of practice. And understanding diagnostic reasoning strategies was also listed as one of the things, and appreciation for the authentic clinical context. Sometimes students, we will teach students IPE in a classroom setting, and they really appreciated it being real life. Suggestions for improvement: pre-screening the teams for the appropriate patient needs and knowing more about the patient. I think we didn't, in some cases, we didn't know much more about the patient than their name and their age. And later on, we discovered that it was more helpful to have a little bit of knowledge about the patients before they come in, and maybe it would be good to have a pre-huddle to learn about them and to design a course of action. It would make it faster too. Okay, next slide. And I will turn it back over to, I guess, Dr. Young.
Okay, thank you, Jim. Just to briefly mention too, we also have a shoulder-to-shoulder project in India that's for children with special healthcare needs. And we've been doing arena-type interprofessional assessments for a number of years. And these are some photos of how those arena assessments work. The teams there are medicine, primarily pediatrics, physical therapy, special education, and applied behavior analysis for behavior disorders. These are children mostly with cerebral palsy, autism, neurodevelopmental disorders. So you can see we use the same kind of team assessment with one member of each profession, including students, including staff at the special needs center, and the family in the center focus. So we've used this same type of model for children with special healthcare needs. Next slide. Okay, so we started, one of the important things about interprofessional care is preparing students for that experience. And so we started doing an interprofessional course on for all the students who attend in 2007. And now there's been over 600 students who, I should say 2017, I think. So there've been over 600 students who participated in this study. And we've also included at times Ecuadorian students who join us as part of the brigades. Next slide. So some of the learning objectives are important that we go through. This is like a 6-week course, a couple of 2 to 3 hours in an evening that all our students have to do. And part of what they do initially is to describe the roles and responsibilities of interprofessional care. And they actually look at what are some of the typical stereotypes that different professions have, and how do we demystify what the roles of different type of professions do. We also go through demonstrating kind of team building and values and principles. And spend a lot of time actually going over social determinants of health and health equity. These are important for students to understand, particularly in context of a different culture. Each of the students goes through kind of a global context of culture and reasoning that different professions do, particularly focused on Ecuador, working on building awareness, complexity of cultural systems, and also just reflect on ethics involved in serving in a resource-limited setting. So it's important that they understand ethical approaches to doing particularly short-term brigades. Next slide. So I would say overall, our successes have been, we've been able to engage with multiple disciplines. The teamwork complex, we've been able to work with complex health issues. We've been successful at continuing a successful interprofessional course for all the students to participate. We've had some impact on changes in local healthcare center and professions, and you'll hear about some of those stories over the next few hours. And it's had an impact on Ecuadorian students and providers in professional care. And I think Dr. Naboa will actually be presenting the impact it's had on her as she attended as a student. Next slide. So our challenges have been recruitment for having all these multidisciplinary faculties for all the brigades. The clinics are very busy, and there's a push for students to stay involved in their core areas. So we've had to take concerted efforts to make sure that we pull students out to have the interprofessional organizations. It's also been challenging to organize a set type of interprofessional assessments, although I think this last brigade showed that it can be done successfully, and we integrate that throughout each day in the center. Next slide. So I think I'll turn this back over to Melody for any kind of discussions that you all have about how to do interprofessional care during short-term brigades.
All right, thanks, Dr. Young. So it's time to brainstorm again. The things we'd like to address in this session are, what are the challenges to adding interprofessional care to either your short-term health brigade or to your work? And have you had any successes with introducing interprofessional care models where you work? And I'll stop sharing so we can see each other. So sometimes I think it's easiest to think of challenges. So perhaps we should start there. I think outside of a free model, it's very difficult to figure out how you're going to pay all of the professionals who might be involved. Is that an issue in anyone's mind? I think another potential issue might be the logistics. So particularly if you're not all located in the same place, how can you incorporate that interprofessional care while making it a short visit? And I think Jim had experience on both ways with that recently.
Yeah, the logistics are a challenge, but they're not insurmountable. And I think it's worth the effort. In this case, I think it was helpful that they brought someone who wasn't a health professional along to help with the logistics. That was me. I had absolutely nothing else to offer the group. So that was, I think, helpful in that way. But then we also discovered how much better it will be. Dr. Christian sat in on the last 3 patients, and we realized how much better it was having him and Mercedes in the room, because they know the patients, plus they're a part of the team. So this interprofessional team became an international interprofessional team, and it was beautiful.
So have any of you tried to incorporate interprofessionalism but ran into problems?
I really hope you share, because I'd like to know if I'm the only one having problems.
Actually, I didn't want to speak again, but yeah, paying for it might be a bit difficult if you don't have funding to cover for that. The project I work for just covers for staff exchange, where people from Africa and other third countries travel to Europe to understand how sickle cell is being managed in those countries and how to be better when they come back home to implement the new international best practices that they've learned. But like running around for the project and logistics can be quite difficult, where people feel, okay, we're not getting paid for this. So am I a volunteer, or or am I just, am I running a charity? Because now you have to use your personal funds to actually achieve what you want to achieve. So it could be really difficult sometimes. So we're trying to incorporate it into the professional workers' daily schedule. So that way, they wouldn't be thinking, oh, I'm not getting paid for this. Rather, it would just be like their day-to-day activities.
I agree with you. I think it's hard sometimes to imagine how it's going to look. I do think the effort that you put in, though, pays off greatly in patient outcomes and satisfaction. Did I cut someone off?
Good morning, good afternoon. My name is Essie Havo, and I just want to add to the discussion. You know, I'm a public health nurse, and working in the health department, we usually tend to work in silo internally. So one of the things that struck me when I took my leadership position is how I work in immunization. So I led the immunization bureau or program. And as you know, in the immunization, all the vaccine we need to track all the vaccine preventable diseases. And we have to work with epidemiology department and also the informatics team. So sometimes it's hard for, you know, some of my colleagues from those departments to understand what we're trying to do in our program. And you ask, did you try to collaborate? And then it did not go well. And as long as I have been in the position, I have tried so hard to make sure that we improve our reporting process, and also which will require informatics team to actually design a different or maybe add additional feature where we can pull the data to see quickly, you know, what are the diseases that are out there that we can, you know, work on. It didn't go well, and I would say that for almost 6 years, we didn't get the program, we didn't get improvement in the reporting. And the person who finally understood, you know, what we were trying to do was there for 2 years, and then she resigned. So, so you know, staffing issue and, you know, internal structure can also be, you know, barriers to interprofessional collaboration.
Absolutely, Essie. And I think that's the thing in the United States we really struggle with is the financial implications because of the billing and payment issues. And I would like to say, if you're in charge of vaccinations, we know you're tired right now. So So thank you for what you're doing.
You're welcome. Thank you.
And Jim makes a comment. Do you want to elaborate a little bit, Jim?
Yeah, there's an organization called Interprofessional.global, and it's a consortium or a confederation of regions around the globe that of folks who are interested in interprofessional education and collaborative practice. There are collaboratives in many regions. There's a Latin American collaborative. There's I won't go through all of them. They're on all continents. So if you're interested in finding partners to help you and participate with and collaborate, this is a good place to start.
Or maybe commiserate, even.
Well, there's always commiseration involved in everything new. So yes.
All right. So if anyone else would like to make a quick comment, we have time for that, or we can go on to our next presentation. Okay. So next up, we have the example of a clinic in a middle income country, and I'd like to introduce the staff of the clinic. There are quite a few here, so it will take just a moment. We have Pablo Boada, who is the executive director of the Fundación Hombro a Hombro since 2013. He holds a master's degree in social intervention from the Universidad Internacional de La Rioja, a law degree from Universidad Técnica Particular, and currently studying for a certificate in the Science, Technology, and Society program at Glasgow, Ecuador, with a focus on social innovation. His work is focused on NGO development and sustainability for the third sector. He has extensive experience in NGO administration, global health, and arts management, and has participated in the Fellows Mentoring Program at the Kennedy Center for the Performing Arts. Kristen Carrion is the chief physician at Centro de Salud Hombro a Hombro and the medical director of Fundación Hombro a Hombro. He received his MD degree from the Universidad Central del Ecuador, and he has completed additional training in HIV, diabetes, and primary health care, and holds a master's degree in tropical medicine from Universidad de Guayaquil, and continues to serve as a mentor for healthcare students on rotation from the University of Kentucky at Centro de Salud Hombro a Hombro. He is focused in primary care and chronic metabolic diseases. Ingrid Ceballos is a psychologist working with the Fundación Hombro a Hombro and directs a disability project based on an initiative from Ecuador's Ministry of Social Inclusion. Mercedes Mero is an interprofessional health promotion coordinator, community and clinic-based social worker, and physical therapy assistant in Santo Domingo, Ecuador, and surrounding communities. Mercedes serves as the home visit lead for Interprofessional Health Brigade teams and serves as part of the Food for All program team. Marciela Morales is the clinic coordinator of the Centro de Salud Hombro a Hombro. She started working at 16 years old as a cashier, receptionist, and assistant at healthcare centers. She holds a bachelor's degree in education and a business management technician degree. In addition to her administrative responsibilities with Hombro a Hombro, she has been involved in global health initiatives as well as community engagement. She believes in hard work and is passionate to participate and organize activities to improve the well-being of communities. Carlos Quesada lives in Santo Domingo and studies computer science. He works for the Global Health Program at Fundación Hombro a Hombro. He was the coordinator of Hombro a Hombro's Interprofessional Health Brigades from 2015 to 2020, leading the Hombro a Hombro initiatives in the Highlands, Amazon region, and Santo Domingo areas. He wants to intersect these experiences with his professional training and continue serving the community. Ligia Salas is the community nurse at Centro de Salud Hombro a Hombro Clinic in Santo Domingo, Ecuador. She provides community-based educational assemblies, conducts health screening, provides community vaccinations, and assists with health consults and provides health education and clinical services both at the primary clinic and through health visits in neighboring communities. This presentation will be in Spanish. As a reminder, there is simultaneous interpretation available. You should see that button that looks like a globe at the bottom of your screen, and you can change your that back and forth to select the language that you wish to hear in. So for most of you, that will be English. So at this time, I'll hand it over to the clerk.
Muy bien, muchas gracias por la invitación. Es un honor estar compartiendo con ustedes este espacio. Bueno, quisiera empezar diciendo que el trabajo interprofesional es un componente importante en la atención primaria de salud. Y esta a su vez se enfoca en el trabajo del individuo, la familia y la comunidad, tratando siempre a los pacientes como personas y no como unas enfermedades realmente. Pues al saber que en nuestro sistema de salud en el Ecuador se trabaja con sistemas de referencia de pacientes por niveles, obviamente de menor a mayor complejidad, este trabajo interprofesional aumenta la resolución de problemas en el primer nivel, donde nosotros sabemos que se resuelve más del 80% de las diferentes condiciones de salud. Asimismo, el trabajo interprofesional de esta manera se convierte en una herramienta que va a mejorar la calidad de atención y que disminuye los probables errores, dudas o desaciertos que se pueden tomar en el paciente, a veces en los diagnósticos o los tratamientos. Esto pues a su vez optimiza los recursos en salud, generando un ahorro en el tiempo, el dinero, el espacio e inclusive en la capacidad resolutiva debido a la demanda creciente que usualmente tienen los centros de atención primaria o nuestra clínica. También es importante mencionar que un buen trabajo interprofesional va a mejorar los resultados de atención, tanto cuantitativos como cualitativos. Y esto a su vez pues produce un trabajo de aprendizaje continuo de lo que es un trabajo en equipo en sí, tanto dentro de la organización, de la clínica, como fuera de ella, con una relación establecida con otras instituciones que son públicas o privadas, como pueden ser hospitales, clínicas, diferentes redes de salud, gobiernos locales, por ejemplo, y otros más. De esta manera se convierte no solo en un equipo de trabajo, sino yo diría en una familia misma. Gracias. Gracias.
Gracias por la invitación. Como bien mencionó Cristian, en atención primaria en salud se trabaja en equipo y se produce un aprendizaje continuo. Por esta razón, en el Centro de Salud Hombro a Hombro se promueve la participación de estudiantes de diferentes carreras para realizar pasantías y rotaciones que permitan poner en práctica los conocimientos adquiridos durante sus carreras académicas. Al mismo tiempo, se busca obtener experiencias profesionales. Los estudiantes participan en actividades intramurales y con mayor énfasis en las extramurales, en donde el pilar fundamental es el promotor de salud, que prioriza casos para ser atendidos. Y juntos con el apoyo de los estudiantes se realizan visitas domiciliarias a pacientes especialmente vulnerables para conocer, analizar, evaluar y recomendar estrategias que permitan mejorar la salud del paciente. Las pasantías tienen una orientación fuerte en la práctica de servicio social. Además, se genera un aprendizaje con intercambio de conocimientos que enriquecen a todos quienes intervienen. En esta práctica han participado estudiantes de medicina, de enfermería, farmacia, trabajo social, promoción de salud, terapia física e incluso estudiantes de diseño y comunicación social, con quienes se ha logrado apoyar a varios pacientes y a sus familias, realizando actividades como, por ejemplo, mingas, charlas, talleres y acompañamientos y hemos visto varias sonrisas en pacientes y esa es la idea de un bienestar completo para nuestra gente.
Salud y Vida un programa de educación comunitario con pacientes que padecen enfermedades crónicas. Este programa se creó con la finalidad de darle un soporte de ayuda educativa y un acompañamiento en su enfermedad a cada usuario. Con este programa nosotros podemos mantener mejores controles médicos y disminuir sus complicaciones para así poder intervenir en la mejora de su condición crítica. Para este programa intervienen muchos profesionales, tales como enfermeras, promoción de salud, psicología, el médico desde la consulta que hace la captación, terapia física y nutrición. Con este acompañamiento de profesionales, lo que tratamos es de ayudar a mejorar la calidad de vida de cada usuario, ya que nuestra afluencia de pacientes es de personas de escasos recursos y nosotros con la educación podemos ayudar al paciente a que conozca su condición y pueda sobrellevar el día a día con lo que está padeciendo. Se le ayuda también en un soporte en su tratamiento, tanto en el conocimiento de la medicación que ellos están utilizando y se les realiza controles médicos ayudándoles a mejorar su condición. Pues sabemos que el acompañamiento en estos pacientes es de mucha importancia, ya que son personas vulnerables de nuestra comunidad y necesitan el apoyo tanto de profesionales como de cada uno de nosotros.
Grupo de VIH. Es una red de apoyo que trabajamos en equipo para intervenciones y soluciones de problemas comunitarios, como es el caso de pacientes que requieren atenciones inmediatas con otros profesionales de la salud. Entender y aprender el contexto de los términos de la salud como son, número 1, el medio ambiente, relacionado con los factores ambientales, físicos, biológicos, contaminación química, tanto del suelo, el agua y el aire. Número 2, el estilo de vida, relacionado con los hábitos personales y grupales de la alimentación, actividad física, adicciones y conductas psicológicas. Número 3, biología humana, relacionado con el aspecto de la genética y con la edad en las personas. Número 4, atención sanitaria. Tiene que ver con la calidad, accesibilidad y financiamiento de los servicios de salud que atienden a los individuos y la población. Se realiza seguimiento a las familias más vulnerables que requieran de apoyo o de cuidados paliativos para dar a conocer cómo obtener mejores resultados en sus tratamientos. Actualización de los tratamientos y abordaje que nos ayudan a conocer sobre sus posibles efectos secundarios. En esta actividad se tiene la participación de médicos, enfermeras, trabajo social, promotores de salud, psicólogos. Este grupo de personas son personas voluntarias que pertenecen a diferentes instituciones como el GAD municipal, Fundación Ortenstein, Consejo Cantonal para la Protección de los Derechos, Fundación Hombro a Hombro y Fundación Paz. Gracias.
Personas con discapacidad. Partiendo desde lo dispuesto por la Convención sobre los Derechos de las Personas con Discapacidad, que obliga a los estados a comprometerse a asegurar y respetar los derechos de las personas con discapacidad. La función como entidad es velar que las mismas tengan una atención prioritaria, igualdad de condiciones, oportunidad e integración económica para que su calidad de vida mejore. El trabajo que se realiza se basa en las necesidades que se presenten en cada uno de ellos. Estas van desde la atención en medicina general, terapia física, terapia del lenguaje, neurología, ginecología, psicología, educación, espacios recreativos, talleres para su desarrollo personal y en unos casos laboral, gestión para la entrega de ayudas técnicas, entre otras. Toda esta labor se la realiza por medio de articulaciones que el Centro de Salud Hombro a Hombro gestiona con el Ministerio de Salud Pública, Policía Nacional, fundaciones, Ministerio de Educación, en pocas palabras, entidades públicas y privadas. Por tal motivo, el trabajo interdisciplinario es indispensable, ya que nos ayuda a cubrir todas las necesidades de cada persona con discapacidad que requieren. Gracias.
Ahora vamos a conversar sobre las referencias de pacientes. En el Sistema Nacional, a través del Manual de Atención Integral en Salud, menciona que las referencias y contrarreferencias son un mecanismo para ayudar a la resolución de salud de los pacientes. En el centro de salud, este sistema se activa cuando un paciente acude a consulta médica y de acuerdo a su condición de salud que encuentre el médico, se hace una referencia para especialidad. En algunos casos también por problemas legales y para atención en asistencia social. Estos pacientes son referidos para una postconsulta. Posteriormente se hace una entrevista para recoger información socioeconómica. Se analiza el caso y se busca la mejor alternativa para hacer la referencia al paciente. Cuando tiene una condición de salud urgente, inmediatamente acompañado por el promotor de salud, el paciente se integra en una unidad de salud. Cuando la condición de salud no es urgente, se registran los datos del paciente y después el equipo de salud gestiona esta ayuda. En estas actividades interviene medicina general, enfermería, promoción de salud, psicología, en algunos casos, el área de coordinación. La finalidad es, entre todos los profesionales, buscar la mejor opción que permita ayudar al paciente y por ende mejorar su condición de salud. En el trabajo de pacientes referidos se encuentran varios desafíos en el camino. Uno de ellos es el problema económico por la comunidad en donde nosotros vivimos, los sistemas de salud saturados y adicional a eso, la falta de insumos médicos que no permite poder ayudar a los pacientes. Y estos tienen que acudir a comprar ya sea medicinas, hacerse exámenes, hacerse otros procedimientos. Otra dificultad también es que no contamos en la ciudad con servicios especializados y toca referir hacia la ciudad principal. Con todos estos desafíos, el equipo de salud trabaja arduamente y se ha logrado insertar a varios pacientes para resolver problemas de desnutrición, problemas e incluso de cirugías. Gracias.
Nuestra clínica se encuentra ubicada en una zona urbana marginal. Esto nos llevó en cada consulta médica a que el médico pueda observar en niños menores de 5 años, adultos mayores, un déficit en sus esquemas de vacunación. Para nosotros poder obtener la vacuna, se hace una coordinación con el Ministerio de Salud Pública, ya que son ellos los encargados de suministrar el biológico de forma gratuita para todos los sectores de nuestro país. se hace una coordinación también previa con el área de enfermería de cada centro de salud más cercano. Posteriormente, acudimos al centro de salud Los Rosales para que nos puedan otorgar la vacuna. La captación de pacientes se hace dentro de la consulta médica. La finalidad de las vacunas es prevenir las enfermedades, y para esto nosotros salimos a la comunidad en conjunto con la promoción de salud, enfermeros, tanto del Ministerio de Salud Pública, con el personal de nuestra clínica, a hacer un barrido en cada esquema de vacunación. Y no solamente en niños menores de 5 años. También entran en este sistema de vacunación adultos mayores, ni con la vacuna de la influenza, niñas de 9 años con la vacuna del virus del papiloma, para así poder obtener un sector que tenga todas las vacunas que el ministerio está otorgando. De la misma manera, dentro de este esquema de vacunación, nosotros hacemos gestión para tener las vacunas de la rabia para nuestros animalitos del sector. Así tratamos de cubrir toda la población y todo el sector con todo el biológico que el gobierno lo da, pero que a nuestros pacientes se les complica un poco obtener este biológico para que sus niños, tanto adultos mayores y tanto personas discapacitadas, no puedan acudir a ser favorecidos con este biológico.
Nuestro siguiente tema es el agua. La ciudad de Santo Domingo aún no cuenta con un sistema de agua potable, por lo que existen innumerables casos de diarrea debido al agua contaminada, así como también problemas de infecciones de vías urinarias, principalmente en el sector plan de vivienda. Este antecedente llamó mucho la atención a la brigada médica, lo que les motivó a realizar análisis del agua, involucrando a un equipo de ingenieros, médicos, enfermeras y así como la comunidad misma, dando oportunidad a nuevas ideas para mejorar la calidad del agua, como son capacitaciones de agua segura por el método de SODIS, tratamiento del agua por el método de cloración, y hervir el agua, que es el método más utilizado en nuestra población. Algo que llamó también la atención en el último tiempo, las personas compran agua en botellas o bidones, y esto los ponen a disposición de su familia. Muchas gracias.
Implementamos la atención interprofesional a través de brigadas médicas. Con esto nos enfocamos en la solución de problemas a un nivel más amplio que solamente el dolor o la molestia física. Durante una brigada de salud contamos con pediatras, odontólogos, terapeutas físicos, gastroenterólogos, cardiólogos, psicólogos y en algunas ocasiones profesionales en leyes. El médico atiende al paciente y analiza si es que es necesario la intervención de otro profesional. Si este es el caso, realiza una referencia interna durante la brigada y el equipo de hombro a hombro direcciona al paciente hacia el profesional que debe atenderlo. Hemos encontrado pacientes que requieren, además de una atención médica, también una atención psicológica o de terapia física. Con esto nos enfocamos en la atención del paciente en su bienestar, más que en tratar o dar una consulta médica simplemente.
Hey, thank you, team. I think that was really helpful to see how an interprofessional thing might work outside of academia. And now it's time to hear from you guys again. So what professionals are you working with now, and where do you still see gaps? So I'll start. I see we have a really pretty good interprofessional team, but I think we still have some gaps with, I'd love to see business involved more because we'd really like to help improve the economic conditions in some of our areas. So that's something on my wish list is more involvement from business. What about some of the other people? Okay, so here's a comment from Craig, an HIV group in Ecuador. So what are the gaps in professionals that you're finding with the HIV group particularly? We'll give a moment for translation.
I just want to ask the group that just presented, you mentioned a group about SIDA, HIV in Ecuador, in Santo Domingo, Ecuador. What gaps are you missing there? I didn't know SIDA was a big issue in the community. I was a little surprised to see that group. What gaps in professionals are you missing?
Bueno, quisiera intervenir un poco en esto. Como en todo el mundo, el HIV es un problema general que afecta a varios países y sobre todo a las economías de cada estado. Primero hay que reconocer que en nuestro país el acceso, por ejemplo, a un tratamiento en estas patologías es súper limitado y muchas veces pues nuestros pacientes no tienen el medicamento necesario para poder realizar su tratamiento. Aunque el tratamiento es parte importante, hay otros factores más que debemos trabajar con la población y también con los profesionales. Hablando con la población, la educación es el factor más importante y parte de esto, de la educación, es la importancia que en cada trabajo interprofesional, las promotoras de salud, por ejemplo, y todas las personas que trabajan en la comunidad sean parte importante del grupo para poder dar directivas y poder coordinar actividades mancomunadas para trabajar en este aspecto importante de la educación en la población, sobre todo con niños y adolescentes. A nivel profesional, podemos decir que es importante que todos los profesionales en nuestro país tengamos una capacitación y un conocimiento bastante importante sobre HIV y SIDA, por ejemplo, y falta la intercomunicación, hablando a nivel de instituciones públicas y privadas, falta la intercomunicación y el trabajo conjunto para poder dar soluciones priorizadas y soluciones prontas a aquellos pacientes que necesitan acceder, sean a tratamientos o sean también a diferentes tipos de exámenes o procedimientos que se hagan en las instituciones públicas. Ha mejorado un poco este aspecto a nivel urbano, digámosle así, sobre todo en las ciudades más grandes, donde se forman redes, por ejemplo, de trabajo sobre VIH. Una de ellas es la que tenemos nosotros en nuestra comunidad y que de una u otra manera se están conectando en el trabajo. Pero en otros casos, por ejemplo, hablemos de las áreas rurales, donde es un poco más complicado tratar de trabajar con los pacientes y donde el acceso al servicio de salud es limitado. Entonces, hay que trabajar mucho más aún en la atención primaria en salud, fortalecimiento de las instituciones de primer nivel, que sea más fuerte todavía en las áreas rurales para poder dar un trabajo de calidad y con calidez humana a cada uno de los pacientes en este aspecto sobre el VIH.
Thank you for that information. The person on the iPhone says that he or she has noticed a big gap in rural areas compared to the inner city. I think that's an important thing that we've seen repeatedly with different diseases and having access to multiple professionals. Did you want to elaborate any more on that? Okay, perhaps
Por
not.
supuesto.
Oh, go ahead.
Claro que sí. Bueno, lo primero pues es decirles que cuando nosotros hacemos medicina rural en nuestro país, usualmente los médicos que terminamos nuestra formación universitaria e intrahospitalaria, somos asignados a estas áreas para trabajar con las comunidades, resolviendo los problemas de atención primaria. Muchas de las comunidades se encuentran en lugares más lejanos, a veces de difícil acceso, y algunas comunidades, por ejemplo, en las áreas amazónicas, llegar o salir es un verdadero reto, que puede tomarte un día entero o más buscando un transporte. Ahora, cuando nosotros vemos en el área rural, hablo un poco de mi experiencia como médico rural, tú puedes encontrar pacientes que necesitan un examen o un test, por ejemplo, de HIV. Empezar con el test del HIV es un problema, porque tú puedes escribir una solicitud de un test, pero este paciente no puede acceder a veces al laboratorio del Ministerio de Salud Pública, por ejemplo, porque es difícil salir de la comunidad, porque es difícil conseguir un transporte, y muchos de ellos, en mi caso, podrían estar mucho tiempo, 6 meses, o a veces no regresar más, o no intentar más, porque no tienen esa accesibilidad. Y cuando nosotros tenemos también pacientes que en estas áreas tienen un diagnóstico de SIDA y necesitan controles pertinentes o su tratamiento adecuado, usualmente no tienes disponibles estos medicamentos en estos lugares. Entonces, el paciente necesita salir de su comunidad, buscar la medicina en el lugar correspondiente, que puede ser un hospital, por ejemplo, que manejen estos pacientes, y a veces el paciente se topa con que no hay medicina en el hospital tampoco. Entonces, es un verdadero reto que estamos trabajando aún en nuestro país. Estamos mejorando, aún tenemos muchas deficiencias, por ejemplo, con estas condiciones, pero obviamente, pues, sin lugar a duda, tenemos problemas con esto, y no solamente con HIV. Estamos hablando de otros problemas más. Estamos hablando de problemas también de enfermedades crónicas metabólicas. Estamos hablando también de problemas de emergencias o necesidades de cirugías emergentes, que no son fáciles de poder trabajar con los pacientes, o del seguimiento incluso, ¿no? Entonces, nos enfrentamos a varios retos como en varias partes del mundo, pero todos estos aspectos hacen un poco difícil poder trabajar con los pacientes con estas patologías.
Hey, thank you everyone for all your comments. I think this has been really helpful. I'm hoping that you're starting to see some new angles for introducing interprofessional care and developing some concrete steps for collaborations to happen for you. Speaking of steps, it's now time for salsa. I'll turn it over to Pablo, and he will introduce Juan Pablo and guide us through some lessons. So this is an opportunity I hope you'll take advantage of to stretch and move a little in the middle of a long workshop. And we'll be looking to our Ecuadorian colleagues to show us the way. All right, so our next speaker is Dr. Maria de Lourdes Nova Lasso, who's a graduate of the University of the Americas Faculty of Medicine. She was born in and resides in Quito, Ecuador. She's completing a Master of Management in Health Institutions at UDLA. She's collaborating with the Timmy Global Health Foundation in 2020. She completed her required year of rural medicine in Guanajuato, sorry, I know I just mispronounced that one, sorry, parish, located in the province of Cotopaxi, Ecuador. She's participated as a student and later as a physician in the in-person UK shoulder-to-shoulder interprofessional health brigades, and is an alumna of the Spring 2020 Virtual Brigade. She'll talk about applying interprofessional principles to a rural team in a middle-income country. Please go ahead, Dr. Nova.
Thank you, Dr. Ryan. Yes, my name is Maria de Lourdes, but you can call me Marilu. And good morning with everybody. I'm glad to share this time with you, and thanks God for this day, and thank you for the invitation of the team from the University of Kentucky and the Shoulder to Shoulder Foundation. I'm a physician, general physician, and I have participated, like Dr. Ryan said, in 4 medical brigades with the University of Kentucky and the foundation Shoulder to Shoulder in Santo Domingo of the Sáchilas. 2 of the brigades as a student, one was virtual brigade that was awesome, and one already as a general physician. And I really can say it's one of the better experiences of my life. And I encourage always to the professional and the students to live this experience of the brigades, because it's really enriching experience. And you learn a lot, especially because of the topic of today, the interprofessional work we practice during the brigades. And where I learned that all the health professionals conform a same team that must work together for the benefit of the patients. We are watching in the screen some pictures of the brigade with different professionals of the health that are from the same university, but before the brigades, I didn't know them. We are all from UTLA, and before the brigades, I didn't know they exist. And the other picture is with 2 little girls from Sáchilas community that are wearing their traditional clothes. Talking about the topic, a rural team in a middle income country. Thank you. I make my rural year in Cotopaxi in Guangaje, that is near to the Quirotoa, because in Ecuador is a requirement from the government to have a license for practice medicine, and we have to work 1 year in a rural area. And today I will share with you all the work of our health team in the rural area. Maybe you have heard about the Quirotoas Lagoon that is in the picture. It's a beautiful place. And I made the slide, please, can you change to the next slide? Okay, I made my rural year in a parish, it's called Guangaje. It's ubicated in the middle of the mountain range, and is also a destiny of the brigades that Timmy Global Health organizes in Ecuador. Guangaje has a very cold climate, and the temperature can reduce up to less 2 degrees Celsius or 28.4 Fahrenheit. And I know that because I lived there in Guangaje for some months. We had a heater, but no one in this parish has a heater also, because Guangaje is one of the most poorest parish of our country, and the people doesn't have an unstable job. They are agricultures, most of them, but because of the low temperatures, they don't have too many products to plant. Also similar as the condition in Santo Domingo, they don't have the basic services, and they don't have a cosmovision. They have a cosmovision very particular of the medicine and their traditions. In the picture that I am alone at your left, no, it is in the same slide, please, Dr. Ryan. In the last slide. Can you go to the last to the previous slide, please? Okay, thank you. In this picture, I am in a community. No. Oh, okay, thank you. I am in a community called Cachapata that to go there, you have to travel 1 hour in car or 4 hours walking. That most of the time is probably you have to go walking because there is no bus to go there. And in the other picture is with my team of work. In Ecuador, the system of health is public and is based in the model of integral attention health, for the acronym in Spanish called MICE. Inside this model, we have the program called Physician of the Neighborhood. In Spanish is El Médico del Barrio, consisting of professional teams work that are called as teams of integral health attention, with the acronym in Spanish EAIS, el equipo de atención integral de salud. Each EAIS or team is conformed by one general physician, one nurse, and one person from the community that have studied for the technical of primary attention of health, with the acronym in Spanish TAPS. This person from the community talks Spanish, and also they talk Quichua, that is the language of the people from the indigenous communities. So they help with the communication with the patients and have the role of interpreters in health attention, especially with all people whom they don't speak Spanish. Also, we have the support of one psychologist, physical therapist, nutritionist that goes to medical center 1 day of the week. And we have help of one obstetrician, odontologist, and one familiar physician for the different team of works. Because these AIs, these health teams, we in my medical center, we were working 5 teams at the same, at different communities from the same parish in Huangaje. So we learn in the rural area the importance of the teamwork and transfer what you have learned in the classrooms to the countryside with the nature and without all the equipments and facilities you have in the hospital or in the health center. Please, the next slide. Dr. Ryan, please can you change to the next? Thank you. In this picture, you can watch how we worked outside of the health center, because we have to work 3 days of the week in home visits. We went to the domiciliary visits and have had activities with every ethnic group. We adapted to each situation and family, like you see in the pictures. The most of the birds here in the rural area, in the communities, are in home. So they call us as physicians or health personnel after some hours of days after the birth. In the home visits, we made physical exam and applied the vaccines and medication. And we had also to explain all the attention in Quechua and in Spanish. So always we have to respect the traditions of the community, that for the pregnancy and births, they go to the midwife, or in Spanish called partera. And if they have some accident or fall, they go to the sobador, or in Spanish, or who is a person that makes some massage for the pain. So the people of the community believes in traditional medicine, and they don't accept at all the established procedures we have in the Occidental medicine, whereby they not always accept to go to the hospital despite the risk of their health and their life. Like you see in the pictures, we have to carry in our bag to each domiciliary visit our diagnosis equipment like the stethoscope, the tensiometer, the scale, the tape measure, the medical receipts, and all the medical instruments and medicines we think they may need as analgesics, antibiotics, and antihypertensives. So in this interprofessional work, everyone has to contribute with their knowledge and ideas to take care of the health of our patients. When the pandemic of COVID-19 started, our job as health workers, everyone I think in every place of the world changed, and we have more responsibility because of this unknown variant of the virus, and everyone was worried about how the virus acts and travels. So the people from the community closed the access to the personnel of health to this parish in Qualitative. And as health team, we started to have many troubles because the fake news, the people started to think the health personnel had been infected with the virus, and they didn't accept the home visits. And in some cases, they didn't accede to that we touch their guys. Also, they rejected some vaccines, them or administer the vitamins. So it has been a challenge to work with the leaders of the communities. And thanks the teamwork is confirmed by TAPS, the people I told you before of the community. We enter to the different locations of the parish and explain them how they must protect themselves of COVID-19. And after many months of pandemic, the community, I'm sorry, I have a trouble in the computer. Okay. I was telling you about the community accepted, after many months, they accepted the home visits. And on many occasions in the care at the medical center or in home visits, for the different reasons, the entire health team was not present. Maybe it was some day the physician, on other day was only the physician and the nurse, but we always can go to the home visits in a complete team. So we have to learn from the other professions to be able to provide the same service when we are all there, all the entire group. And as well, we are not without the staff as nursing or the primary health care technician. So I try to learn some words in Quechua or communicate with the public, with the community. Please, can you change to the next slide? So also added to this topic and talking about it, I have included some pictures with the colleagues and now friends I made in the brigades in Santo Domingo, and also the people with the community, like the boy in the rectangle in the lower right. I have learned this work like a team during the brigades I made before my rural year, and it is useful for me in our professional life and helps understand what are the activities of the other professions. Because in the brigades, we make not only as students, we don't make only our practice, our profession like physician or medicine. So also we can go with the psychologists or go to pharmacies. That is useful for know what activities they have in the other professions. And with that, we can share our knowledge and also ask without fear, because we are always learning, but also you can teach what you know, because when you transmit your knowledge, you learn 2 times. So I have the next step. After watch the model of work in the brigades, I applied it on other health events with my classmates and in the university in the rural year and now in the work I have. So after you learn how to work and lean in the other profession, it's not only the physician who has to take the decisions. Instead of that, is having an open mind to hear the nurse, the physical therapy, the psychologist, the odontologist, the pharmacist, the midwife, the technical primary attention in health, and all the rest of the team for take care of the patients, taking in consideration that is best for them, what is best for them, and not only what the clinical studies or clinical practice guides has published. Please, can you change to the next slide? So finally, I asked my friends of physical therapy that studied also in the University of the Americas, and we met at the Brigades to share with us what it had lived or learned with interprofessional work in the Brigades, and here are their testimonies. Can you please play the videos, Dr. Ryan? We are not hearing the audio.
The experience that I just said, the guys are really impressed that memory is I never forget because it was my first experience like that. We never do that before. And I think it gave me the opportunity to change my mind, okay, to share information, to share experience with guys from another country, okay. And I think it was very important for me because I learned how the humans can be with other humans, the human that all have all of us. I think the brigade gave the opportunity to persons who can access to health service, to give that access, give that the chance to share pharmaceutical, to share therapy. And I think is the main reason why I got the shoulder-to-shoulder brigade. And for sure, by encouraging to share again that experience with a new team, and for sure I will do the
I'm not sure, is the sound quality good enough to play the second one? Craig says no. Let me start it and see, and if it's not, we'll stop it. Yeah, I'm afraid it's not going to be quite good enough. Can you summarize what they were saying, Mary Lou?
Yes, they were explaining us their experience as physical therapists and students first, how we met the other careers, or share our experience, like at the end of the day, we have this patient with this trouble or this pain, and as physician, we can give some analgesics, but maybe not their pain is not enough aliviado. like they don't feel good enough. So it's better for us as physicians to refer this patient to the physical therapist. And this work together is the one we learn in the brigades, and we encourage all the people to have in their health teams. So I'm sorry for the audio of not hearing today, but now I can tell you that we work together. I work with Alan, with Danny, with Jonathan, and now we are friends of other careers of health. And finally, for finish my intervention, I want to take this final message that everyone is important in my team work. Nobody is less or more important to take care of the health of our patients. If anyone has any questions or comments, maybe at the end I will respond them. And also, if anyone wants to contact me, I will write my phone number and email and in the chat. Please remember always a message from me: smile, be happy, and God bless you and your family.
Hey, thank you so much, Dr. Novoa. So our next time is to start to think about how are we going to engage the professionals that maybe you're thinking about now. So any thoughts that you all have would be great. So perhaps you've thought of some people that would be great to engage. Maybe you're like, wow, I never thought about a physical therapist, but I should have one, work with my patients. How can you reach out to them and make some plans for that? Okay, here's a comment about engaging more mental health services. So then I think what you would need to do, and Jim, feel free to jump in here, is figure out where there are mental health services in the community and start a dialogue with them.
Yeah, I think sometimes we make this more complicated than it needs to be. You said it well, find out where the people are that you want to engage and simply ask them. I mean, I think if you compare your experiences that you're having with patients and what your needs are and how they can help, typically if they can, they will want to participate with you. There may be some logistics and some other issues to get past. We talked about some of those things earlier, payment and things like that. But you can get past those, and it's complicated. I mean, that in the United States, at least, I mean, that's the hope of value-based payment as opposed to fee-for-services that will get past the payment issues and focus on quality. It would be different in other countries, but people typically want to do the right thing. It's been my experience. And so I would start there. Not very scientific, sorry.
Great advice. Any other thoughts or comments on this? How you would reach out to people? Sometimes it takes putting it on your calendar to remind yourself. Okay, I want to go on with our final presentation now. Share the screen, get it up here. So we're all familiar with the travel problems and restrictions that were caused by COVID. Those affected us in Kentucky and in Ecuador and of course around the world. So our last speakers, Pablo Boada and Craig Borey, will discuss a virtual model that we developed. You've already met Pablo, so I'll introduce Mr. Borey. Craig Borey is a program manager for the Office of Global Health Initiatives and the director of Peace Corps Prep at the University of Kentucky. He holds a Master of Science degree in Community and Leadership Development from the University of Kentucky. and a Bachelor of Science degree in Business Management from Colorado State University. He is a returned Peace Corps volunteer and a board member of the Kentucky Peace Corps Association. He currently volunteers locally with former refugees from Burundi and Congo, and wants to talk with you about the importance of serving others both locally and globally. I'll let you all take it away.
All right, thanks, Dr. Ryan. So my first slide. So it's the end of the world and I'm shopping for hand sanitizer. What are we going to do? At the University of Kentucky in Hombro Hombro in Santo Domingo, COVID sacked our plans for travel. We had an interprofessional group planning to leave for Ecuador in just 1 week. How are we going to be able to help provide health services to our stakeholders and service learning for our students? International travel was canceled in many places of the world. How could we use 20 years of the status quo excellence with US and Ecuadorian alumni now into the thousands, with tens of thousands of community members served with health services? We needed to have some sort of income, and we wouldn't wish this on anyone. We wouldn't wish COVID on anyone, and don't hate me for saying this, but this disastrous historic trauma wasn't all bad. Our interprofessional colleagues helped us find something positive in it, but we'll get to that a little bit later in my story. Next. In the next 15 to 20 minutes, we're going to share about creating a virtual interprofessional experience. Is there anything that you would like us to specifically cover? Please post questions and comments in the chat. The pieces for assembly are in this slide, pieces and instructions for assembly. We'll share a short overview of who was involved, the technology we used, how we recruited participants, show a snapshot of a typical day, and then offer thoughts on what we learned in the process. Next. But first, back to our story. In March of 2020, our US-based interprofessional program, Shoulder to Shoulder Global at the University of Kentucky, had almost 50 professionals and students ready to go to Ecuador for an interprofessional short-term experience in global health, otherwise known as a brigade. Our Ecuador-based interprofessional colleagues at Hombro Hombro were ready to receive this US-based team and had patients from the communities lined up, hotel reservations made, and Ecuadorian faculty and students ready to work shoulder to shoulder, pun intended, with us. Communities in Santo Domingo, Ecuador waited to receive these teams' health services. Each time we discussed concerns about COVID, our March Brigade's Chief Medical Officer, Dr. Ceballos, kept wincing like this and looking like she was just trying to take it all in, albeit with a scrunched nose instead of lips. All stakeholders were pensive. The University of Kentucky's International Health and Safety team wanted to know current hospital capacity in the communities we serve. Medicine and nursing wanted to know if they would be able to have enough equipment like PPE. Pharmacy was worried about isolation times and drug supplies. And the Ecuadorian logistic team worried about creating safe spaces. Communities worried about infecting the interprofessional brigade and the brigade infecting the community. During a few stressful days, Ecuador and US-based community and university teams met, and just like that, and with pained expressions, we decided it would be best to cancel our in-person time together. From an administrative perspective, it was one of the hardest decisions we've had to make, but we're not here today for that story. Next. We decided to use these same pensive interprofessional stakeholders to help solve the puzzle of what would be next. After all, sometimes complex problems require multiple know-hows. To keep operations running, we needed to have an income, engage a community and the brigade safely, and prepare students for an interprofessional world. After much discussion with these stakeholders, we started putting together a community-led interprofessional virtual brigade. The goal was to produce an interprofessional and community-based experience for all. The virtual brigade would be, from what we could find in the literature, the first interprofessional academic-based virtual health brigade ever. But much like my middle school years, at 12 years old, it wasn't that cool at the time. We were just trying to keep things rolling with all of our friends and colleagues in the communities. As part of the planning, we talked to our paying customers, the students, to see if a virtual option would even be something they would be interested in. The answer was a resounding maybe. The experience would be different and better than we had ever hoped, but don't let me jump ahead just yet. Next. As the pieces and instructions slide showed, we needed a platform to host a virtual experience for everyone. For this virtual interprofessional brigade, we used two platforms, Canvas, which many of you in the academic world are familiar with, and Zoom, which all of you are familiar with, or you wouldn't be listening to me here to tell this story. This image is the opening page of what our virtual experience looks like in the Canvas platform. This photo is somewhat old, as the clinic's name is now the Centro de Salud Hombro a Hombro, the educational site where much of our interprofessional training occurs in Santo Domingo, and as you've seen with other presenters, where we do most of our work. Next. The other platform we used as our stage is Zoom, just as you're using it now. Did you know that once you have your meeting set up in Zoom, you can edit the meeting to include the language interpretation function that you're using now? Here's how you do it. Go to the meeting settings, scroll all the way down to find the meeting's advanced settings, then you will see language interpretation. It should allow you to turn it on or toggle it on. Ours did not. We eventually figured out to contact Information Technologies to look at the contract with Zoom and have the feature enabled for the whole community at no extra charge for the whole university. You can see the languages that somebody put in here on this slide, but don't be fooled. It's still manual interpreting. It's just that the participant in the meeting will be able to button select which person they want to hear, the voice of the interpreter or the person speaking. Next. In order to not go bananas like these health promoters in front of the Centro de Salud clinic, we recruited stakeholders that could represent different professions in Ecuador and the US throughout the virtual brigade experience, as we wanted to produce an interprofessional theme. The team in Ecuador recruited community leaders that they have worked with for years. Shoulder to Shoulder Global made marketing materials, and he had each profession champion recruitment in their own field. Our marketing idea was that participants could have an interprofessional and international experience without ever getting on a plane. Next. Here's one of our participant recruitment tools we used for marketing. This was our first flyer for the August 2020 Virtual Interprofessional Health Brigade. And personal marketing messages sent from each of our professional champions, the focus was on the interprofessional piece and the offer of an international experience without boarding a plane. As you can see, in our haste and hurry, none of these ideas are in this flyer. My email in this flyer is for prospective participants that want to learn more. We sort of hoped not many people would take us up on this offer, as it was our first time to roll it out and we didn't know how it would look. We now have a better format to accept applications from prospective participants. When you do your interprofessional virtual experience, you should decide if you want to use your email or some other way to receive information like the prospective participants' career field, international experience, what their goals are for the experience, etc. Next. Okay, so what did this look like? Here's a sample of the schedule. This is in Canvas, the platform we decided to use. The blue arrows show where we held discipline, our professional specific presentations and discussions. Each day started with virtual patient consults, the orange arrow at the top, that highlighted professional specific areas such as physical therapy, pharmacy, medicine, public health, or nursing. This sample schedule shows discussions, including the consult and a workshop around nutrition with perspectives from a nutritionist, a physician, a nurse, and a pharmacist. If you'll notice, participants of the virtual brigade watched a home visit on this day at 9:15 a.m. The wrap up at 6 p.m. involved the highlighted profession for that day, holding an interprofessional discussion about what participants learned that day about that specific profession. In addition to the interprofessional pieces throughout this 1-week virtual experience, all interprofessional participants learned about the national healthcare system in Ecuador, the public health, social determinants of health, immigration, and local and international aid organizations. Next. Of course, with the patient's previous consent, we started each morning in clinic with Nurse Ligia and Dr. Christian. Ligia is hiding in the background, hopefully not in a sack in this. This particular patient presented with an unusually large mark on her face, as you can see. You might not be able to see, but there is a much interprofessional and international exchange discussion going on in the chat, one of your strongest tools to keep the flow going. Next. Here's a sample of a lecture and discussion by Public Health at the Universidad San Francisco de Quito. One benefit of creating a virtual interprofessional experience is that if you have internet, interprofessional resources become local anywhere in the world. Next. Just like the in-person experience and what you did today with salsa, a professional dance instructor, Juan, led students in real time through a salsa dancing lesson. Many participants reported that the cultural components of the cultural buffet and dispersed throughout the week helped create bonds with other participants from different cultures or academic backgrounds. During this and a few of the other sessions, some participants expressed that they forgot that the experience was even virtual. Can you believe that? Next, please. Okay, so a few tips as you put together a virtual interprofessional experience. After all, this is a blueprint of how to do it. Look through your materials beforehand to make sure each stakeholder will understand the context or background of vocabulary that may be professional and discipline specific. In our example, participants received background on the community in Santo Domingo, Ecuador, names and roles of the different individuals in the virtual experience, and pre-watched virtual tours of places where they would be virtually present. We also had an individual active in the chat to type out acronyms used by speakers or briefly explain organizations or terms that may not have been understood by all in different professions and countries. Next. Okay, a few virtual interprofessional brigade flow tips. The amount of work required to put on a virtual experience is no joke, or said in a different way, not easy, since jokes don't interpret well. You can find yourself scrambling anxiously during technology or participant issues. So we have a few additional tips for you. Next. Flow tips. Oh, we'll wait for that. Oh, there we go. I was going to use one of my flow tips. One person should be running the various technology or platform parts while another is your master of ceremonies, much like I'm talking and Pablo's talking, but Dr. Ryan's running the slides. Running the platform could mean pulling up slides, managing the chat, recording and keeping a tab on participants for anyone forgetting to mute, and managing uninvited guests, also in English known as trolls. There should be a couple of assigned co-hosts in case the technology quits for one. The show can go on through another person. Not sure that we're following this learned behavior specifically today, but remember to get people moving every 40 minutes or so with a break. Have a related fun fact sheet for the co-host in case the primary speaker's technology quits or there are other delays. For our example, we wrote up a sheet of sharing items such as Ecuador being a world's top banana producer and rose exporter, famous people from Ecuador and Kentucky, and fun facts about the different professions. This will help melt away pauses in the flow that can seem like an eternity. As a final flow tip to help you keep your show on the road, take daily notes of what you would like to do to improve the experience the next time. Next. Okay, so you saw on my assembly slide, the last piece is what did we learn from all of this? What did we learn from stakeholders rolling out our own interprofessional and international virtual experience? Comments from both the Ecuadorian and US participants were quite positive for the first experience that we offered in August of 2020. For example, now I have a good picture about the importance of interprofessional collaboration. Every profession has something to contribute in any case. The only real feedback of concern was the amount of screen time that we had, much like you're experiencing today, and how we broke it up a little bit with salsa and brainstorm. For the second time we offered a virtual experience, we put this virtual brigade show on. We were able to offload any lecture material and readings for participants to do outside and before the sessions. Some participants liked this much more, and some didn't. Additional comments included a US-based international diplomacy student sharing that she believed her disability would preclude her or prevent her from ever being able to participate in education abroad. This virtual interprofessional experience opened the world of possibilities for her and others, including some that wouldn't typically be able to afford an in-person experience in another country, but were able to pay around 1/5 of the cost compared to the in-person experience for this truly interprofessional opportunity. Next. Okay, perhaps our most significant finding of all was received from the community that we typically serve, and it wasn't the black and white outcome that we expected. Community members, including the interprofessional Ecuador-based clinic staff, shared how teaching as a part of this international interprofessionally focused virtual experience was empowering for them, giving them additional ethos within the community. Next. Our story continues now that we've done some virtual interprofessional programming. You can do it too. In your own personal tool bag, we hope that you have some tool ideas for a virtual interprofessional experience planning team, a platform you can use such as Zoom or Canvas, how to recruit stakeholders, how to create an interprofessional schedule, and understanding some feedback and tips to keep things flowing. Before I get back into my plastic safety bag, thank you for listening. And Pablo and I are happy to answer any questions in the chat, and best wishes for you on your virtual travels.
Great, thank you so much. So thanks to everyone for staying until the end. I hope we have provided you with additional information about the ways that interprofessional collaborative practice and education can enhance what you do for your patients, whether that's a short-term experience in global health, a clinic, operating in a rural area, or in cyberspace. We've enjoyed hearing about your experiences as well, and are happy to hear some more, or to have some more discussion at this point, or answer any questions. You should feel free to place those in the chat, or just unmute yourself and we can talk. And I think probably all of the speakers will be happy to put their emails in the chat if you have further questions later.